Is the microphone on? Yes. Good morning, everyone. Fantastic to see such a great audience at this wonderful event. Yes, it falls to me to introduce you to the domain of inflammation and repair. And it's a double act, so I'll very quickly pass over to my much more talented colleague, Kimme Hyrich. So our domain is led by Sir Mike Deegan, who is Chief Executive of the Central Manchester Foundation Trust Hospital, and he's ably supported in that role by the Medical Director, Mr. Bob Pearson. Professor Phil Turner, who is an orthopaedic surgeon and recently appointed as Clinical Director of the newly formed Manchester Centre for Orthopaedics, is our clinical lead. And I, in my capacity as the Institute of Inflammation and Repair leader, take the role of academic lead within MAHSC. Now, I suspect that lots of you, as Mark hinted, will be wondering what areas of clinical practice or research does an Institute of Inflammation and Repair concern itself with? In fact, those two processes underpin just about every common condition or disease that any one of you, probably more than half of you here, at some point in your life will experience. So, if I can just begin to give you some insight into those different areas. Tissue, we organise ourselves into a number of different groupings, and I'll go around them, but tissue injury and repair, and one of the main areas of research there concerns joint replacement. Now, I'm sure everyone knows someone who's had a joint replaced at some point in their life, and with an ageing population, this is a growing challenge, and it's a huge burden on the NHS. So it's really important that we firstly find ways of making our joints last longer, but if we do need a replacement, that indeed those replacements too last as long as possible. And in that context, it's important to have research that's innovative and looking at different ways of repairing damaged joints. Our musculoskeletal theme is concerned with different types of arthritis. So inflammatory and non-inflammatory arthritis are both life-limiting and disabling conditions if not appropriately treated. In fact, by the time we're at 75, almost half of us will have sought medical advice for osteoarthritis. And that particular form of arthritis is indeed one of the main reasons that we might need a joint replacement. We are also interested in dermatology, and we have research focusing on skin diseases that affect people across the lifespan. So whether it's eczema or psoriasis. And I think interestingly, we have a major theme of research that looks at the psychological consequences of living with a very obvious skin disease, as well as pioneering research that's looking at better methods of treatment for all these skin diseases. We're interested in the causes and consequences of renal disease, both acute and chronic kidney failure. Unfortunately, many of us will find ourselves, or hopefully not many, but some people will find themselves in need of intensive care, whether that's the result of a major trauma, and there's a whole range of clinical challenges surrounding that area of the domain. For respiratory diseases, again, these are diseases that can occur across the lifespan, and for conditions like asthma or chronic obstructive pulmonary disease, these are diseases that are really increasing in prevalence in our modern era, and there's a huge challenge learning how best to manage these lifelong conditions for people. There are many causes of gastrointestinal diseases, and we have a range of research tackling questions as diverse as how do you teach someone to learn to swallow again after they've suffered a stroke, or helping people to live with conditions such as inflammatory bowel disease or irritable bowel syndrome. Now, in the University of Manchester, in the Faculty of Life Sciences, inflammation and repair is a theme of research. And within the Faculty of Medical and Human Sciences, we have a whole institute for researching questions around inflammation and repair. And it's a real help having this synergy from basic science through medical research, linking up with our MAHSC domain for applied clinical research, really helping us to absolutely capitalise on the incredible science base that we have here in Manchester, and making sure that our world-leading science is rapidly translated to make a difference to patients who suffered from the whole range of diseases, including those I've just shown you. So just by way of a couple of examples, we have fantastic opportunities here to use cutting-edge technologies in an area of medicine called stratified medicine. So we can now use approaches that will let us look at the whole range of proteins or genes that are being expressed or metabolites in the body. And we can use these measurements in patients with disease to actually characterize them much, much more carefully. And this means that we can use a much more targeted approach to picking out from often a range of treatments which one is right for the particular patient in front of us. Now, this area of stratified or precision medicine is something that Manchester is becoming incredibly well known for. We've received recently over £25 million worth of funding that's going towards equipment and infrastructure to support research to do stratified medicine studies in areas such as asthma, rheumatoid arthritis, psoriasis, systemic lupus erythematosus, amongst others. Our interconnection with the University of Manchester extends also into the Faculty of Engineering and Physical Sciences. And we're working with the discoverers of the graphene, this amazing new product, to look at how that might be incorporated into developing new biomaterials, which will be vital for developing these new approaches for tissue injury and repair research. So I hope I've given you a couple of examples how across the board we can really capitalise on an excellent science base to make sure we do the best, not just for the patients in the Northwest, but obviously all over the place. Now, like the other domains, we've set ourselves a number of targets, and I've listed some of them here. And these are mostly health-related targets. But I just want to say that I particularly am passionate about making sure that this excellence carries on and that we're training the health professionals and researchers of the future. And that's a very important target for us in our domain. So I'd now like to introduce my colleague, Kimme Hyrich. Kimme is a rheumatologist, an epidemiologist, but she's also a world-leading expert in the use of biologic therapies to treat patients with rheumatoid arthritis. And I think through the course of her presentation, you will understand why the target that I've highlighted on here is a particularly important one. So over to Kimme.
So thanks, Jane. So joint pains are common. I'm not going to ask for a show of hands, but I bet you right now there's a lot of you sitting out there getting comfy in your chairs because your back hurts. Some of the older people may have creaked as they sat down this morning. But 1 in every 100 of us is living with the most severe form of arthritis, which is called rheumatoid arthritis, or RA. And RA is more common than we think. It's estimated up to 700,000 people are living in the UK. It's estimated there's probably 20,000 people right here in Manchester living with severe, severe rheumatoid arthritis. And rheumatoid arthritis isn't just a little bit of pain. This is a chronic, painful inflammation of the joints. It's disabling. It causes you to lose your job. It's destructive. And sadly, it's associated with up to 10 years earlier death. This is a patient that probably hasn't had rheumatoid arthritis for very long, and you can see if you focus on the knuckles, it's not projected that well, but they're quite swollen, and already you can see one of the fingers is a little bit crooked. Perhaps, rather than me tell you about rheumatoid arthritis, I'd like to introduce you to Susan. And Susan is someone living right here in Manchester with rheumatoid arthritis.
I was actually first diagnosed with RA in 1995. An express train. Something I didn't want to hear, something I didn't want to know. I knew about RA. Now whether that made it worse or not, I have really no idea. The unbelievable fatigue, the pain in many of my joints, the not being able to sleep, the not being able to do the things that you would normally do, even dressing and undressing myself. It not only affects me, it affects all my family, it affects all my friends, it affects everything that I do.
So this next image is quite upsetting. This is what hands of people that were diagnosed with rheumatoid arthritis back in the 60s and 70s might have eventually looked like before we had very effective treatment. I think the treatment of rheumatoid arthritis took a big turn in the late 80s when we started to use regularly methotrexate, a drug you've already heard about for the treatment of leukemia, as a mainstay of treatment for rheumatoid arthritis. Unfortunately, this drug isn't effective for everyone, and many people had terrible side effects. And although we manage them a little bit better right now, we knew that there was something better we needed to do to treat this disabling condition. In the late 1990s, the first clinical trial of a drug called infliximab in rheumatoid arthritis was published, and I think this was the moment that the specialty of rheumatology changed. And since that time, we've now had 9 biologic drugs licensed for treatment of rheumatoid arthritis. And Susan, in 2003, started on a drug called etanercept, and here's what her experience was.
Well, considering I wasn't really sure what biologics were going to do for me, they were beyond my expectations really, because after I started taking them for about 6 months, as I say, I could actually get myself dressed. It wasn't always so easy getting undressed, but at least I could get myself dressed. And the fatigue, that reduced quite a bit, so I was actually able to do more in a day than I used to be able to do. But also the pain was so intense, 24 hours a day, but that greatly reduced with the biologics, and I think still greatly reduced with biologics. So yeah, they made a huge difference, biologics. But it certainly reduced my pain by, I would say 75%. It also increased the mobility of my joints. I could move my joints an awful lot more on the biologics. And my power pack, as my husband calls it, so how much energy I have in a day, was increased with biologics.
So we've just heard from Susan, the biologics for many patients represent a very powerful, effective treatment, which is really starting to give patients with this disease their lives back. However, we do know now that the experience that Susan had has not been everyone's experience. These drugs are also incredibly expensive. 3 of the biologics listed earlier represent 3 of the 5 highest income-generating drugs in the United States last year, generating billions and billions of pounds, costing on average the NHS £10,000 a year to prescribe. The other thing is, once these drugs came to market, we started to hear a little bit of scary things about them. Heart failure, serious infections, in worst case, patients who were starting these drugs then developing lymphoma. And we started to ask, well, why are we starting to see side effects of these drugs that weren't reported in clinical trials? Well, we know that at the point a drug gets its license, it's actually very few people in the world that have ever experienced it. And anyone involved in clinical trials here knows these are often short-term, selected patients. They don't follow patients for years and years and years. And as an epidemiologist, that's actually the group of patients I'm interested in. What's going to happen when we now use these drugs in hundreds and hundreds of thousands of patients around the world that have other diseases that are going to take these drugs for 5, 10, 15, 20 plus years? And to put that into perspective, we imagine this as a cohort of 20,000 patients with severe rheumatoid arthritis. We'll give these patients biologic drugs, and we know a lot of them will get very well, but some of them won't. We also know that some of these patients will have a side effect. And as epidemiologists, we collect data from all of these patients and try to make sense, to try to understand, well, who are the patients that are getting better? Who is having a side effect? And 15 years ago, here in Manchester, in collaboration with the British Society for Rheumatology, we decided to do just that. And at the point these drugs were coming on the market, we established a large national patient register. We're now following close to 25,000 people across the UK receiving biologic drugs, including 2,000 patients right here in Manchester. And by collecting information long-term on these patients, as they come on drugs, as they go off drugs, we're learning a lot about them. And we're improving their outcomes. So I mentioned that old-fashioned drug methotrexate. Biologics in this country are currently used for patients with arthritis that tried methotrexate and it didn't work. But we discovered through following thousands of patients that in fact, if you didn't stop the methotrexate, but just continued to take it and add the biologic on, you're almost 2-fold as likely to have a really good response. And we worked with NICE to incorporate this into national guidelines. And year on year, the number of patients staying on methotrexate is increasing. And year on year, the number of patients we put in remission is increasing as well. The drugs are associated with serious adverse events, but it's important to try to identify, well, which events and how often, to help patients make decisions about their best treatments. We know that there's a 20% increased risk of you having a hospitalized infection if you go on this drug. But I think journalists like to talk relative risks, and epidemiologists like to talk absolute risks. And in fact, for every 100 patients treated, only one patient had a serious infection. So most people aren't having this. You're probably wondering why I have pictures of blue cheese and raw eggs in a talk on arthritis. But we found by following all these patients in the biologics register that we saw a 100-fold increased risk in infections caused by Salmonella and Listeria. These are infections that are commonly found in these types of foods. And we worked with Arthritis Research UK, which is a national arthritis charity, which generates patient information leaflets for patients. And we put a food warning into the information patients received. And since 2006, we've seen a 75% reduction in the UK in these infections. We've confirmed that at least over the first 5 years of therapy, these drugs are not increasing the risk of cancer, which was a great fear for us when the drugs first came on the market. And finally, I think this is a really exciting time, usually, for most women. It was for me. But rheumatoid arthritis is a disease that can really strike in the prime of your life, right around the time that you want to consider starting your family. And if you're finally feeling really well on a new treatment, this is the time that you want to consider having children, but equally your doctor telling you you have to stop your therapy could be a devastating blow. And until now, all of our treatments were needing to be stopped before you got pregnant. But through our British register, we've now followed 130 women that either had a oops or chose to stay on this medication when they became pregnant. And those women experienced no increased risk of birth defects, no adverse pregnancy outcomes. And based on our understanding on how these drugs work with the placenta during pregnancy, we know that it probably is safe to stay on these drugs, at least until conception. But of course, that's an area that we need to continue to monitor. So I've presented to you the results of an area of research called pharmacoepidemiology. And I've shown that the systemic prospective capture of outcome data on large cohorts of patients can actually change the way that we treat patients. It can really improve the outcomes that we're seeing. And the register here, based in Manchester, has really become a worldwide exemplar of drug safety. It's been adopted widely. It's been endorsed by the European Medicines Agency and truly is changing the way we're treating rheumatoid arthritis. So thank you.
Thank you very much indeed to Kimme and Jane. It's time for my idiotic questions now. The thing you were mentioning at the end there, Kimme, and it does strike me that in the same way as other presentations, look at something which has a particular use within the inflammation repair domain, but actually this use of epidemiological registers, presumably you could use it right across any medical sphere that uses drugs or even a treatment group.
You do, yeah, you can, and indeed we are. And right here in Manchester, we're running similar studies now in psoriasis, in pediatric arthritis. This is being rolled out in multiple sclerosis. The model of observational drug data is one that is being adopted widely. It's not easy. You need really clever statisticians because you can sometimes come to really wrong answers about things as well. But it is a model that is being adopted widely, and I think it's been a huge success both to rheumatology and other specialties.
How do you engage with this big number of patients?
You engage patients, I think, want to be engaged with. Mm-hmm. And we're very lucky to have a very strong National Rheumatoid Arthritis Society here in the UK. They're our advocates. They work with us in planning. And, you know, hearing talks earlier about mobile technology, these are novel ways we can even capture data for studies like this. So it's an ever-evolving, but I think...
Using email? I mean, actually, quite literally, how does the patient send in their details?
They can send them in a lot of ways. study started back 15 years ago, uses pen and paper.
Right.
But increasingly, we're now using web portals, we're using mobile phones where people can actually send us their data on how severe their arthritis is through the air, I guess.
Yeah, because Jane, that was the thing that just struck me in thinking about the app, the Clint Ouch app earlier. You could presumably have an app as part of the way that you're engaging with people.
Absolutely, and I think using modern technologies is something we're exploring a lot in our domain, and particularly in rheumatology, particularly children affected with these conditions. They're much more interested in using something like an iPad or a phone to tell you things than actually a questionnaire. I think one of the important things I would say is that at the outset of studies such as these, one of the really important stages that we go through is to discuss our thoughts and ideas with patient groups. So we find out from the patients themselves what method they think would be the most appropriate way for them to collect data and information. And that may well vary depending on whether you're working with children, middle-aged working people, or old-age pensioners. So I think it's really important to choose the right approach for the particular studies that you're doing, and probably to offer people a range of opportunities.
And it's an important point, isn't it, about who patients are? Because you made the point that actually many people in this room may well be suffering, or I think you made the point as well, may well be people who are potential patients if they're not patients already. So it's not them and us. It really is actually about using our own experiences within the sector and also those of our family and our friends as well, and getting that information.
I think that's one of the exciting changes that I've witnessed in the last 5 or so years, really, that the patient voice is being listened to much more carefully. Sometimes talking to patient groups, they've even come up with research questions that we wouldn't have thought of asking about. So sexual health for rheumatoid arthritis patients, for example, was not a topic that our team had thought of asking questions about, but actually the patients wanted us to ask questions about that.
Fascinating stuff. Thank you both very much indeed. Kimme, Hyrich and Jane Worthington. Thank you very much.